Good morning from Ukraine. I am extremely grateful to Tom Born for the invitation and such a warm introduction. Hopefully we have a successful session. Good morning, everybody, wherever you are. ISUOG plus FMF Ultrasound Essentials 2026 is a great initiative gathering ultrasound specialists from all over the world. For those from low-resource countries, this is a unique opportunity not only to see and hear top experts, but also to ask their questions. I encourage all of you to type your questions in the dedicated chat box. A speaker's discussion and Q&A time slot are scheduled at the end of the session. The year 2025 has become a year of breakthroughs in artificial intelligence. It is a game changer for our profession in the near future. But we are still here and now, and every new working day in our ultrasound rooms, we face new diagnostic challenges, and we still solve them not with artificial, but with our own natural intelligence. The upcoming session will focus primarily on ovarian masses, but it will begin with aspects of reproductive medicine. A one-stop ultrasound-based approach to subfertility assessment by Thierry Bosch. Our first speaker is a professor at the University Hospital Leuven in Belgium and the author of more than 150 publications and over 100 presentations at international congresses. His clinical research focuses on the diagnosis of endometrial and myometrial pathology, endometriosis, and fertility. So please welcome Professor Bosch.
Hello, thank you to give me some time to discuss with you the concept of a one-step ultrasound-based approach to subfertility. To assess subfertility, there is a lot you can see on ultrasound. I will not try to cover the topic, but it's in a short time. First, there are the ovaries to see if there's a corpus luteum, follicles, and you can also see pathology, just like endometriomas. If you see a ground glass cystic lesion, and if you see an endometrioma, you know you have to look for other lesions of endometriosis. So that's an important information. If you want to see the tubes, well, usually the tubes are not so easy to see unless there is fluid inside. But if there is spontaneously fluid inside, that's bad. That's bad news, because that's in hydrosalpinx and means blocked tubes. But otherwise, the technique we use to see a tubal patency is high accuracy using gel foam, so we call it high fuzzy. And because the gel foam is hyper-echogenic, you can see this contrast running through the tubes just to confirm the patency. You don't need that much. You need some gel, some water, a pediatric Foley's catheter, and a syringe. That's what you need, and then you will see. You will have well, you see the echogenic contrast here coming into the cavity, and then you see if you inject a little bit more, you see it running through the tubes here. You see it, you can see it, you can follow it, you can see the flow, and you can see how tortuous the tubes are, and if there is some hidden hydrosalpinx with dilatation or something like that. Okay, what about the cavity, about the uterus, the corpus? Well, that's more than the cavity, because of course you need a good cavity, but a triangular cavity is important to a certain extent, but it's more important to have also a nice endometrium junctional zone and allowing myometrial waves, uniform vascularization, and a nice myometrium. And of course, if you see that inside the cavity you have something, a polyp or a fibroid, this may impact the fertility indeed. You may also have congenital uterine anomalies. There are a lot of different classification, somewhat confusing indeed, but we know from previous systematic reviews that in the septate uterus is allegedly associated with lower pregnancy rates, higher miscarriage rates, and preterm birth, whereas in a bicornuate uterus, that does not affect that much the pregnancy rate and the first trimester miscarriage, but more, well, prematurity and fetal malposition. So, well, it looks simple. If there is a septum, well, it might affect the subfertility. It's not that simple. It's not that simple, and that's why there are studies demonstrating that resecting the septum is beneficial for fertility. But they were the Dutch coming and they said they did randomized trials and they said, oh, there is no difference. So what's the reason for this discordance? Well, probably because we look at different things. Because here that's a septate uterus, and that's also a septate uterus with all the definitions available now. But you see, it's different. It's different. So you have this normal septate uterus. It's not. You have also this septate uterus, and that resembles more the bicornuate. If you see, there's only the difference between those is only that there is a little triangle here, the one you see here, of tissue filling this gap. But the vessels just follow the bicornuate architecture. It's you see it at ultrasound that it's something else, and you see at ultrasound that you can see not only the endometrium, you can also see the junctional zone. You can, putting on the color, you can see that the arcuate vessels are following the band. So it's a different type of septate uterus, and I think that's something we have to look at in the future, and that's why just restoring the triangular cavity might be dangerous, because then you go too deep and you're, if you will, you resect the snow bridge, and that's why we have some cases. We had some cases with rupture through the fundus after septum resection. So be aware of that, and even more with T-shaped uteri. Is it normal? Is it abnormal? We don't know yet. I know quite some of you want to restore the anatomy to the triangular anatomy. That's perhaps not always a good idea, and we recently had some reports of an increased risk of placenta accreta after surgery for T-shaped uterus. It also is a case with any surgical procedure affecting the junctional zone will increase the risk of lesion of the junctional zone, and so of adenomyosis. And here we come to the next point. Adenomyosis, also something you have to look at. We know the direct and indirect signs. You can scan the QR code if you want to have more details about that, but that's very important. Adenomyosis perfecta is perhaps one of the more recently recognized important factors in subfertility, and of course it's not always iatrogenic. You have also due to pregnancy, due to hypercontractility, this might also cause adenomyosis. And what's the effect on fertility? Well, on different levels. I mean, it disturbs the hormonal balance, giving more hypercontractile uterus, leads to inflammation, leads to the stimulation of COX-2, prostaglandins are secreted, and then this also affects again contractions and hormones and so on and so on. So it affects fertility. So it's important to recognize that, and there is much more research needed on that topic. Well, talking about adenomyosis, it's even more complex than that, because in literature they show this tell about focal adenomyosis, not focal and diffuse adenomyosis, but it's more complex than that. If you look at focal adenomyosis, there are different types of focal adenomyosis with each their own pathogenesis, own symptomatology, and clinical significance also as to subfertility. And for instance, if you look at the adenomyosis of the outer myometrium, this is it more resembles deep endometriosis, and it's more associated with deep endometriosis indeed. And this brings us to the next point, that if you see adenomyosis, just look also for endometriosis, because there is a known association between both. And that brings us to the last point you have to see in your one-stop fertility assessment using ultrasound, is to look for adhesions, post-PID adhesions, or after adenomyosis. Look for adenomyosis, and learn to look at the bowel to recognize the deep endometriosis of deep bowel lesion, and if there is invasion of the mucosa, you will have the typical moose antler sign of adenomyosis, as you see here. Also, try to train yourself in looking at the uterosacral ligaments, and to look if there is deep endometriosis there. And here the ligaments are more hyperechogenic, and what you have to learn to look at is to look for the ink stain in the ligaments, so that you can see if there is deep endometriosis in the ligaments. And usually it's a patient who will tell you where it's painful, and where it's painful there you expect to see a lesion, if there is a lesion. And that's important information as to the fertility prognosis of the patients. So just, well, you understand, one-stop fertility clinic scan is not a 2-minute scan. Okay, I try to tell you all we have to look at in 10 minutes. So, and it's hardly feasible to do that. But use your scan. Take your time to use 2D, use 3D, use color, use saline installation to look at the cavity, use foam to look at the tubal patency. And well, if you do all that, you can have in your, let's say, in 20 minutes time, you can have a lot of information on the prognosis of the patients as to fertility. Thank you very much.
Thank you very much, Professor van den Bosch, for this brief but comprehensive presentation. I'm not sure that we actually have time for discussion. What do you think, Tom?
Yeah, well, I think we've got a minute, because Thierry has been so admirably to time. So not good.
Yeah.
Good, I have to say. Just maybe a question, because I think, what do you use as contrast? Are you there, Thierry? I can't actually see you, but what do you? I can't see you because of the size of the headphones you've got on. They're so big I can hardly see your face. But anyway, it's not everyone can afford to use expensive, like you probably, you might use Instilogel or whatever you might use. So what is an effective contrast that you can use, which would be available for people, irrespective of income?
But the thing is, if for the cavity, you can use saline, so that's very cheap, and it's very useful to look at the cavity. And we use gel and Instilogel because that's cheap for us. But of course, if you want to look at the tubes, you need a little bit of you need air bubbles, so you have to mix the gel with some water and a little bit of air, and then you will have this gel foam. I think you can we have it available because there's you can buy it in Belgium, but you can use some use just a mixture of water and air to have some echogenicity, and this works also quite well. But the most effective is to use gel and gel water and a
And
little
obviously,
double.
then some it depends on your prevalence of infection, but I mean, covering antibiotics, presumably you use when you're testing tubal patency, or what's your policy? Or if it's a one-stop clinic, you probably don't screen them, you probably just give them antibiotics, or what do you do?
Yeah, well, at our center for fertility patients, we use prophylactic antibiotics, azithromycin, one shot, one tablet of 1 gram. But I know there's some discussion about that. Some say it's not needed. I think it depends on the population, of your population, and the prevalence of STDs in your population. But we use it as a routine.
Well, I mean, it's not particularly harmful, is it? So it's not an unreasonable thing.
No.
Inessa, do you have any questions?
Yes, I do. I have a question to Thierry. Tell me, please, briefly, if possible, what do you think about preconceptional ultrasound checkup, pre-gravidary? I mean, not in patient with subfertility, with infertility, but beforehand, in advance, with some prophylaxis aims. Do you support this conception, this idea?
I think to an extent it's if you do it without knowledge, it will be dangerous because you will create a pathology. Because I'm quite scared if you will then see a septum, you will resect the septum. You see a T-shaped uterus, you will resect. Then I guess the patient who has no fertility history, I would be very hesitant to react on what you see, because most if there are no symptoms, there's no history of subfertility, I think you have to think twice or more than twice before you try to treat something that has no symptoms yet.
Okay, great. Thank you.
Okay, so Thierry, thank you. I'm going to buy you a microphone for your birthday, so you don't have to wear the big headphones in future. Okay, I'm just worried about your hairstyle. No, it worries me. You're not going to be on the front of GQ magazine if you wear these big things, you know. So thank you very much indeed.